It gives me immense pleasure to welcome all of you, both in person and online, to the 16th session of the Academic Hour Continuing Professional Development Lecture Series, organized by the Clinical Society of Base Hospital Mahiyanganaya, together with the Branch Union of the Government Medical Officers Association. Today's lecture will be on abnormal uterine bleeding, common problems and management, a frequently encountered scenario in females of all age groups in the field of gynecology. It will be conducted by our very own consultant obstetrician and gynecologist, Dr. Ruwan Wickramasinghe. I cordially invite Dr. Hastagunasinghe, our other consultant obstetrician and gynecologist, to introduce the speaker for the day. Thank you.
Thank you, Viruni. So the speaker today is Dr. Ruwan Wickramasinghe, who is one of my senior colleagues. So he is a graduate from Colombo Medical Faculty, and then he obtained his postgraduate qualification MD in Obstetrics and Gynecology in 2016 from PGM Colombo, and after that he also completed his MRCOG UK in 2018. So he's going to talk about a very common problem related to the periods, and he will tell the topic actually. So it will be useful for everyone, especially in the field level, the general practice, and for all of us. Over to you, Dr. Ruwan. Thank you.
First of all, I would like to thank Mahiyanganaya Clinical Society and the Government Medical Officers Association to give me this opportunity to talk about this common topic. This is actually my topic is abnormal uterine bleeding. It's a common problem. Actually, it's a common problem. Today, actually, I think it's almost 1/3 of the gynecology. Therefore, I am not in the. I thought of not going to talk about the very detail, but I am mainly focused on because there's a non-gynae people, non-gynae doctors are here. Therefore, I mainly concentrate on what is the present, what is the problem, and how can we diagnose, and how can we manage in the mainly the outpatient setting and the general practice setting. This I think it's a more useful for the everyone other than going for the in-depth talk about the abnormal uterine bleeding. It's a very otherwise. Also, it's going to be a very long talk because I told that it's 1/3 of the gynecology is abnormal uterine bleeding, and it's a very common thing. Okay, this is the all the lectures. I am first discuss about the important definitions, then the assessment and the common condition. I mainly focus on the common consider which come across in a daily practice, mainly in the outpatient setting and the general practice, because uncommon things are anyway we are managing in our unit. Therefore, it's not anyway you are referring to us. Therefore, I am mainly concentrated about the general, mainly common thing and the outpatient and first line management. Okay, before we go to discuss the abnormal, we have to know what is the normal. This is because of there are several nomenclature we use like dysfunctional uterine bleeding, polymenorrhea, metrorrhagia, and these kind of words. Therefore, Federation of International Society of Gynecologists and Obstetricians regarding the what is the normal period and what is the so it's a very important to know that what is normal, because when we are assessing the patient in with the abnormal uterine bleeding, we have to take a history, and because it's a very useful knowing that normal thing when we are taking the quick history and assessing the patient and treating and referring to the gynecological side. Mainly they have talking about the 4 components: frequency, duration, regularity, and volume. Frequency means how frequent we are getting the cycle. That means as we all know in the medical student day, we are talking about the 28-day cycle. So normal menstrual cycle is 28 days, but in the practical situation, I don't. There's a majority of women are not getting. So it's differ. Most of them are getting in between. Therefore, there's a range given. Its frequency is up to 24 days to 38 days is a normal. That means if someone getting 26-day cycle, it's also normal. That means that if it is a less than 24 days, it's abnormal. It's more than 38-day cycle, it's abnormal. During this range is considered as a normal frequency. And the duration is normally less than 8 days. 2 days to 8 days is considered as a normal. And the regularity means how regular is period. So consider its regularity. We have to take a little history about what is the shortest cycle and what is the longest cycle. The cycle length is normally considered as the first day of the one cycle to first day of the next cycle. We have to ask what is the longest cycle. These cycle is less than 7 to 9 days. It's considered as a normal, but more than 10 days, more than 10 days is considered as abnormal. Normally these come in the few. I'll later explain this. In the polycystic ovary disease, mainly they are present with a very long cycle, which is like a 45-day cycle. Sometimes they are getting a 2-month cycle, like a 60-day cycle, and in between they are getting like a 28-day cycle. That means this kind of a that's called irregular cycle, this kind of situation. And the volume is previously there's a measurement says 80 ml for blood for one period, menstrual period is normal, more than 80 is abnormal. But now it's still there, but our NICE guideline group is given a explanation to the volume, saying that menstrual blood loss that does not interfere the woman's physical, social, emotional and even though it's more than 80, it's considered normal, but 80 ml cutoff still is there. This is the normal. What is this? A normal normal parameters for menstrual cycle. So, of any parameters are considered as abnormal uterine bleeding. Now there is no other nomenclature. Any bleeding is a menstrual bleeding cause is considered as common called as abnormal uterine. Even there's no perimenopausal bleeding dysfunction, though we are using, but all the groups agree to the concern, the gynecological main groups agree to this nomenclature cause abnormal uterine bleeding. For it give the uniform management throughout the world. This abnormal thing is which we are consider frequency. One is absent, that means amenorrhea. I will later in my presentation I will little discuss about the amenorrhea, because it's also little bit common presentation in the your general OPD setting and the general practice setting. And the infrequent cycle, as I told you, cycle getting when getting a cycle more than 38 days cycle is considered as a infrequent cycle. If getting frequently as less than 24 is a infrequent cycle. And the duration is more than 80 is abnormal. Regularity, I told you, more than 10 days, the shortest and longest cycle is considered abnormal. Flow is now it's considered as a affecting quality of life. If it is affecting a quality of life of the woman, it's considered as abnormal. It's a little bit subjective, but it's a 80 ml, because no, we can't measure the 80 ml blood loss during the period, and therefore this agreement came because affecting a quality of life. Before I move into the management, because this all the definition are important when we are assessing the patient, because if you are getting a quick history, you can assess the how is the regularity of cycle, and it's come across the to diagnosis and give the treat, or either refer to the gynecological team. Acute abnormal uterine bleeding means if it is a uterine bleeding episode, there's this first episode which need the immediate intervention to stop the bleeding. Further blood loss, that means he's getting a heavy bleeding which will affect her quality of life, and also this is like a low hemoglobin level, which needs acute intermenstrual bleeding. We need to treat then and there. Chronic intermenstrual abnormal uterine bleeding means bleeding is coming from the uterus. It's abnormal in all parameters. So any parameters, it had been present majority of the preceding last 6 months. That means the last 6 months she is getting a bleeding abnormal parameters of that which I have to discuss earlier. This is called chronic abnormal uterine. It's after having irregular cycles for several months. And the other two important things is intermenstrual bleeding. It's an important finding because it's not very it's not a common means abnormal uterine bleeding between well-defined menstrual cycles. It can be a mid-cycle. In the middle of exactly in the mid-cycle, they can get experience a small spotting-like thing, or either before the menstruation or just after menstruation, they can experience that, or they can have a intermenstrual bleeding any day of the period. I will coital bleeding. It's also very important thing to ask the history, because it's one thing, it's most always associated with the most of the time is a pathology. Therefore, it's very important to ask this also in the assessment. Then you can refer to the gynecological further gynecological assessment. Another thing is postmenopausal bleeding. It's also genital tract bleeding that occurs. Post mean if the woman experience the period for more, not experience the period for more than 1 year, just goes as the menopause. In the average, our Sri Lankan woman, some may experience a little early, some may experience little later menopause. If it's a woman complaining about the pervaginalization of her period, is considered as the postmenopausal bleeding. It's a very important red flag symptoms in the gynecology. Therefore, I will explain later in my management. Even though it's not bleeding, dysmenorrhea is also important finding to come to our differential diagnosis with the abnormal uterine bleeding. Dysmenorrhea is a cramping low abdominal pain during the menstruation, which is also common thing, but most of the women are tolerating with that, the simple analgesic, but some women are not tolerating with simple analgesic, which may need a further intervention. So there's a two type, primary and secondary. Primary means cramping pain which starting from the menarche and it's continue for the few years or until the throughout the reproductive period. But secondary one is the most important thing. The thing is, because it's a new onset cramping pain without previous normal menstrual cycles, which is almost most of the time associated with the pathologies. Maybe the common association like thing which can be associated with the secondary dysmenorrhea. Therefore, these are the important things I mentioned in the assessment of the abdominal uterine bleeding. This definition. Thing is, if you, even though you are busy outpatient setting, if you can the quick history of the problem of this patient, because I am next going to give the causes of the abnormal uterine bleeding. For that, you can have a quick idea what is happening, whether you can treat outpatient or whether she need to refer to the further gynecological assessment for the gynecological clinic. If you spend a few minutes with your patient in outpatient setting, you can have a good, you can improve your management on gynecological abnormal uterine bleeding. Then its a prevalence is like a 25%, 40 to 25%, and that means one woman in out of four is experience this condition in throughout her life. And these are the core. Palm and the coin. Coin is they have added the E in between for the causes. This is the causes for abnormal workout from the FIGO group. FIGO means, as I told you, Federation of International. With a multiple expert panel, they have developed this mnemonic for to make our life easy to causes for abdominal uterine bleeding, which is very helpful when we are assessing the patient. Palm is P for polyp. Polyp means endometrium. If you take a history, polyp can be present with abnormal uterine bleeding and intermenstrual bleeding. Therefore, if you are taking history, you can just think about is a component is a structural anomalies. Most of the time, you may need these things, these conditions. Therefore, if you suspect the structural causes, better to refer to gynecological further for the structural anomaly. And the other one is non-structural bleeding. And the adenomyosis is another common thing after, most probably after age of 35-40. With it normally present with the bleeding, irregular abnormal uterine bleeding, most of the time the dysmenorrhea, secondary dysmenorrhea. Can be, if you have the patient come with a secondary dysmenorrhea and the abnormal uterine bleeding, you can think about the adenomyosis. And the fibroid, leiomyoma means fibroid. Fibroid, there are three types of, in the FIGO classification, there's a different big classification saying 1 to 7, but it's a very difficult to keep in mind for the normal setting. We, as a gynecologist, we are using that, but but easy way is in the medical student level period we learn submucosal, intramural, and subserosal fibroid. Submucosal fibroid means is the most problematic fibroid for the abnormal uterine bleeding. That means the fibroid coming to the endometrial cavity. Intramural fibroid means it's a fibroid which found in the myometrium, and the subserosal fibroid is the most harmless fibroid. It's a pedunculated fibroid outside the uterus and connected to the uterus by the pedal. Then the submucosal fibroid is the most problematic problem. It's cause the irregular bleeding, and the intramural fibroid also can menstrual bleeding, but also same time it can cause the dysmenorrhea also. And the malignancy, anyway, it causes irregular bleeding, malignancy and endometrial hyperplasia. And the non-structural causes, coagulopathy, it's still there. If you are thinking about the patient presented with a heavy menstrual bleeding tendency, like he's experiencing heavy menstrual bleeding since menarche, or she is having other bleeding manifestation, you can refer to the investigation for the coagulopathy screening also for the found the cause. And also we can, then the ovarian dysfunction, it's another common cause, my presentation, because it's a common presentation to the outpatient setting. And the endometrial causes means the local endometrial cause, it will not understood still, but even though it's classified, therefore I am not going to talk about much detail. And the iatrogenic causes, other one is you can come across in the general practice, because common iatrogenic cause is contraceptive methods. As you all know that subdermal implant, jadella or imipronone, can cause the irregular abnormal uterine bleeding. Either they can cause amenorrhea, they can cause anyway the initial period of the insertion, woman can experience the unscheduled bleeding for the jadella and imipronone. And also other one is a levonorgestrel intrauterine device that is called Mirena, cause irregular abnormal uterine bleeding mainly in the introduction first 6 months of the insertion, and also later also they can cause amenorrhea. Even the copper use experience a little bit heavy bleeding during the menstrual period. And other one is IM depo that also cause several abnormal uterine bleeding problem. Therefore other iatrogenic causes maybe the warfarin like drugs. These are the other iatrogenic causes. That common cause is contraception, is the abnormal iatrogenic cause is the abnormal uterine bleeding. And other one is not otherwise classified, which is these are the included like atriovenous malformation, which can find in the rare presentation. These are the things this category. And then we after this one I will little bit discuss about the few common presentation to the outpatient department. The amenorrhea, it's a amenorrhea is this is a part of the abnormal uterine bleeding component. It's a frequency with the frequency. Amenorrhea there's a two type of amenorrhea, primary and secondary. Secondary is the most common presentation for the outpatient patient and the general practice. But primary amenorrhea also there. So very important to identify the primary area. For this need to refer properly to the further management. There's a two kind of primary amenorrhea we are talking about. One is as you know that secondary sexual characteristics. Secondary sexual characteristics mean when the girl become before that in menarche, it's first start with the pubic hair blood, which called pubarche. Then the breast development come. This is it's called telarche. Then the same time it's a growth spurt also going on, and then the last is menarche. So a girl not attain the menarche at the age of 13. And without secondary sexual characteristic development, it should be referred to the further assessment. There are several causes. I am not going to discuss the several causes because it's a long list, and so I don't think it's going to be any it's a general practice, because anyway you have to refer to the either gynecologic clinic for the further. Girl who have with the secondary sexual characteristic, but at the age of 15 he is if not attained the menarche. So it's another one. This also need to refer the further management, because don't try achieve the withdrawal bleeding like using northeastern or something, or oral contraceptive pills, because these things are need to evaluate, because these 15 years old girls who are not attaining menarche with secondary sexually characteristic may be a rare syndrome called Mayer-Rokitansky syndrome, which is absent uterus. Therefore, even though you give the with northeastern or no oral contraceptive pill, to achieve the withdrawal is not going to happen. Because it's very important to refer these patients, because sometimes it's missed for the, if you not refer, we can we can do the, especially girls with 13 years, girls without secondary sexual characteristics, we can do the management accordingly with the help of the endocrine team. Therefore, it's a very important to refer those patients to the when you diagnose these patients. The second one is secondary amenorrhea is absent menstruation for 6 months following a regular cycle. It's a common thing. You can find in the general practice, you can get these patients. Like mainly the common cause is polycystic ovary syndrome, and after age of 40 these ovaries are gradually failing, and therefore they can experience this kind of a presentation. You can get these kind of patients. And as I told, there are several causes for amenorrhea that I am not going to discuss here because it's going to be taking another half an hour for discussing and management amenorrhea. But you need to prepare appointment. And I just want to little bit discuss about the hormonal management, hormonal amenorrhea. This is WHO have classified this ovarian dysfunction amenorrhea for the three groups. As if you remember, ovarian the hypothalamus pituitary gonadal axis. That means the hypothalamus secreting gonadotropin releasing hormone, and the pituitary is FSH and LH. Then the ovaries releasing the estrogen and progesterone. This patient, there's a failure of this axis, then cause the amenorrhea. Another one is group 2. It's a common. This is the group I am going to discuss here. It's a one with the polycystic ovary disease. They have a normal estrogen, normal hypothalamic ovary. Therefore, they are coming with. And the group 3 is a gonadal failure. That means the low estrogen. Because of that, the FSH is high. It's a gonadal failure. This can be rare. This is also not a common thing. And therefore, I thought about this little bit discuss about the polycystic ovary disease, which is a common these days because of the even this change of our lifestyle, dietary pattern. It's mainly going with the goes with the high BMI and the menstrual problem. There's a Rotterdam consensus to diagnose the polycystic ovary. If you see this consensus, that's why I want to tell this. Even you can general normal doctor without ultrasound scan, you can diagnose it because you need two criteria out of 3. Need to present the 2 out of 3 criteria to diagnose the disease. One is oligoannulation. Oligoannulation means the main problem is anovulation. Anovulation means normally if you take the menstrual cycle, first half is mainly our proliferative phase, second half is a secretory phase. That means first half mainly controlled by the estrogen, second half mainly controlled by the progesterone. After the ovulation, trigger to the secretory phase is mainly controlled by the progesterone. What happens is if this ovulation not occurred, this second half cycle is not go to the second half, and it's still to continue the proliferation phase. It's exposing the estrogen more than expected, and it's proliferating, and it's at the that endometrium proliferate to a certain level, it spontaneously start the bleeding without any proper date. Therefore, that's why they are getting a long cycle and irregular bleeding. If it is you can diagnose this. You can diagnose the oligoannulation. That means they are most of the time. That means there's no ovulation. That means the anovulatory cycle. It's also common in the after 40 because after age of 40 also anovulation can occur. Anovulation cycle are getting more and more. Therefore, they are also experience a long cycle like a 3-month cycle, and again bleeding after 3 months of amenorrhea and with the heavy bleeding. Therefore, it's a one thing. Another is a hyperandrogenism. So that means the high androgen. You don't need to do the testosterone level to diagnose hyperandrogenism. You can. There are clinical features. With the clinical features, you can diagnose like acne and the hirsutism, excessive hair growth, and also the blackish discoloration. You can diagnose these things. This is if they have these 2 criteria, you don't need to do the scan, and you can you need to do the scan and do the diagnose the polycystic ovary. Ultrasound criteria is ovarian volume is need to be more than 10 milliliter, or either you have a follicles less than 10 centimeter, more than 12. With the other 2, you can diagnose the polycystic. The important is polycystic ovary syndrome. It's a common. Now it's getting more common, and you can actually do the initial management at the general, because main if the high, there are most of the girls are in the higher BMI, having higher BMI, but there are few ladies with a normal BMI. These are the very difficult customers to manage in polycystic ovary, but they can, gynecology, you can refer them straight away to gynecology. But even though you are going, when you are referring to these patients to us, gynecological unit, you can ask to start the weight reduction, because weight reduction and lifestyle modification is the mainstay of management of polycystic ovary syndrome. Because they say if you lose by the weight in the present weight by 10%, you can have a regular normal cycles. You can start the normal cycle. Because what I notice is most of them these girls are having told by after get married these things are will settle, but it's not going to settle, because marriage is not a treatment for any treatment for this polycystic ovary. Therefore, better to start, at least advice on the better. When you are referring to the gynecological clinic, you can start the advice on weight reduction. If they explain more happy to lose some weight, they will do that. That's the one thing I want to tell. Please, at least recovery in your level, you can start the weight reduction until you are referring to the gynecological team to management, because polycystic ovary is giving a more lot of problem during the life. It can be give the fertility problem anyway, because they are not getting a regular cycle, and other thing is in your counsel you can tell these their main worry is they are not getting a period in every month in the 28 days. You can we can tell it's a, you don't need, the woman don't need to get a, it is better they are getting a period in every month regularly. But if you are not getting, it's okay if you have a period for 1 year. That means every 3 months if you are getting a period, it's fine. It's more, you can't go if you are getting a period, your period not getting more than 3 months, you need to have a withdrawal bin, otherwise it's fine. Therefore, you can explain that it's okay, not to worry. You can, if you are getting a period for every 3 months, is also at the moment fine. But you can start with the weight reduction, and that will improve that. Then the other thing, if you are for the management, you can use the combined oral contraceptive. It's one option, because it's have a home estrogen and progesterone preparation. This will give the proper regular period until they are achieving a weight reduction. We can offer the oral contraceptive for the management, but it's not really necessary. If you are getting a, you can give a 3 month, every 3 months, like a withdrawal achieve a withdrawal period in northeastern. It's fine. Short course of northeastern can be done. And the other one is they are present the polycystic ovary syndrome. Other than that, they lead to uh, non-communicable disease in the later life, mainly the diabetic and hypertension, and also is they are high risk for the endometrial cancer in the later life. Therefore, you can educate those things, and then they will be more motivated to reduce some weight. Then it will be a settle the most of the problem. And the other one is if there is a fertility issues, they might need ovulation induction. Therefore, if there is a fertility period, you have to refer to gynecological clinic for the further management of the fertility device. Then the other common problem is abnormal uterine bleeding in the teenage girls. This is also a little bit common, because few years of the menarche, after menarche, even though they start the bleeding, there is a hypothalamic gonadal axis is not well established. Therefore, they can experience the infrequent cycles or the heavy frequency cycle like that. This thing you can actually do the you can reassure them, or if there is a complete heavy bleeding, you can refer to the gynecological clinic for the assessment. Otherwise, if they are getting into infrequent cycle, you can ask just to wait for few months and see how these things happen. If not getting corrected, they can go to refer to the gynecological clinic. And also they are young girls is having a polycystic ovary disease, and also eating disorders also can cause the menstrual problem like anorexia nervosa and these things also, but very rare. It's rare, but it can cause percentage like that. For that also you can try non-hormonal drugs. I will explain later what are the non-hormonal drugs we can try, and the oral contraceptive is also the option, and the progesterone only pill is option, but it's not available in the Sri Lanka. Right, before moving to management and things, I just want to discuss the intermenstrual bleeding. If you see the causes, most of the causes are they have a like a ovarian causes are like a eastern secreting tumors, and the uterine causes contraceptive method transport, but infection, polyp, fibroid, and malignancy are the uterine causes. Cervical causes are also cervical polyp, infection, and cervical malignancy also can give the intramenstrual bleeding. Cervical ectropion also possible can. So, and the vaginal causes are infection and malignancy. Therefore, it's most of the time it's associated with the pathology. So my advice is if they have found the menstrual bleeding, better to refer gynecological clinic for further management. Don't try to manage in the outpatient setting or general practice setting, because you might miss the malignancy or some info, some red flag pathology if you for the intermenstrual bleeding. Uh, then the other one is postcoital bleeding. It's a not very common thing, but still the associate most of them is associated pathology like a cervical malignancy, ectropion, and infection. Therefore, postcoital bleeding best is referred to the gynecological clinic to manage, because these are not common things. But therefore, these patients need to refer by gynecological clinic. I'll just go explain the basic things, basic investigation we need to do. Uh, with the history and all, if you are suspect, anyway, we need to have irregular abdominal uterine bleeding. You need to do the full blood count to assess the hemoglobin level. It's a good practice to do that. And other one is if indicated protein profile, and if there is a clinically symptom suggestive of a thyroid dysfunction, you can do the TSH, because thyroid dysfunction can cause the irregular abnormal uterine bleeding. These are the basic things you can do in the thing. And if they are suspecting anyway, now is the abnormal uterine bleeding, most of the time, most of them are referring to us for the ultrasound scan. Ultrasound scan can for the structural causes, at least you need ultrasound scan or further imaging. And the other things are saline sonography we are doing here for the, and hysteroscopy is for the biopsy, and the pipel biopsy is to take the biopsies for the diagnosis. And the in general practice level, I think full blood count, if necessary, protein profile or TSH is a good investigation to do while referring to the gynecological team for further management. And this is the other thing. What we can do in the outpatient. This can be started as initial treatment, and also you can start this in treatment while you are waiting for refer to the gynecological clinic, because same days we might not go. Therefore, you can initiate. These are the initial treatment you can do. The abnormal uterine bleeding, first line management according to the standard guideline is a levonorgestrel releasing intrauterine devices, intrauterine system. That's mean the Mirena. It's not, unfortunately, it's not freely available in Sri Lanka. Even though it's a private sector, it's a very expensive. I think it's like a 40,000 or something for thing. Therefore, it's not a freely available. Even though it's a first line, it's not freely available for us. Then we can, the second line is a non-hormonal management. So tranexamic acid, then mefenamic acid. So easily you can start. Any patient you can start this one. Dose is tranexamic acid, so 500 milligram 3 times a day, and mefenamic acid 500 milligram 3 times a day. You can try for the 3 cycles. If you are not settling, you can need to refer to the gynecological team. Only for the one go, you can give for the 5 days only. Don't give the long course of tranexamic acid and mefenamic acid. There's a one cycle 5 days. If not, and you can try even 3 cycles. If not responding, better to refer to the gynecology team. Other one is a oral combined oral contraceptive pills. It's a good drug. It's a come for the contraception, but it's a good. It has shown there are a lot of non-contraceptive benefit in oral contraceptive pills. Like it reduces the menstrual blood flow, it reduces the dysmenorrhea, and it's reduce the chance of getting ovarian malignancy and the endometrial malignancy, even the bowel malignancy in the later life. Therefore, oral contraceptive pills are they have a very good non-contraceptive benefit. We are using as for the treatment. No, other than the contraception, there are several preparations, because oral contraceptive in the several came with several generation of progesterone. Main problem is the weight gain here. Therefore, now there are newer preparation coming. They are not associated with the weight gain, but it's a little bit expensive. These are the drugs we can try. The third line is it's oral progesterone, like a northestrone. It is commonly used in the general practice. I think it's better to not to use in the general practice, because problem is that it's anyway cause the, when we stop that, it's anyway cause the withdrawal bleeding. When the, if you prescribe the this thing for 5 days, patient will get better. After 5 days, then patient stop the drug. Another 2 or 3 days again the problem started. Because normally we are giving the long course of northeastern in the gynecological practice. Therefore, I think it create more problem giving a very short course of northeastern to stop the bleeding. It will stop the bleeding for few days, then it stop again the bleeding reappear, and patient again going behind. They are most of the end up, they are coming to us with the saying treatment has taken but not settle, and again restart after stopping the drugs. Therefore, I think so oral progesterone little bit use the little with the caution, you giving with the for the heavy menstrual bleeding in the outpatient setting. And the other one is injectable progesterone for the Depo-Provera injection. I think it's not commonly used in in the Sri Lankan practice for the stopping the bleeding, but we can use. We are also not commonly use that because injectable progesterone have a lot of side effects. Which have weight gain, bloating, and all the progesterone side effects are causing, because we are giving a very high dose of progesterone for the patient. And the other one is a GnRH analog. It's not commonly used in the even our gynecological setting in Sri Lanka, but I mentioned it's for the completion. Then these are the common thing. I think easily you can start the mefenamic and tranexamic, and if not responsive to refer to the gynecological side. I think far better option than the starting this progesterone thing, testosterone, because it can make the problem more worse in the patient, right? If you're not using properly this testosterone. Okay. And to the last, I thought about that little bit discussed about the post-menopausal bleeding. It's a very important thing. Uh, if you see the causes, I have given the definition. There's a bleeding, one bleeding from the genital uterus after 1 years of cessation of the menstrual cycle. As you see, it's a association with malignancy, but it's a 10% association with the endometrial cancer. But we can't miss the 10%. Most common cause is endometrial polyp, and you can have the fibroid, and these other things are there. Uh, because of that, this endometrial CA, the I think as I believe the gynecology it's a good cancer, even though cancer is a good one, because it's present, we can diagnose early because it's present with pervaginal bleeding. Then patients are presenting early, and if we can diagnose, we can identify in the early stage and treat. Compared to the ovarian cancer, because other gynecological cancer, mainly the ovarian cancers it's a presenting very late because there's no symptoms. Ovarian, it's come in a very late stage, like a patient develop the ascites and all. But in the uterine cancer, its main benefit is, main thing is, even though it's a cancer, it present most of them present early. Uh, if we miss, if we diagnose and properly identify that, we can do the good job for patient. Therefore, the postmenopausal bleeding, we have to think about the always, even though 10%, always think about the endometrial cancer. Because I agree that 90% is not an endometrial cancer, but we can't see who's going to be who are in that 10%. Therefore, it's very important to refer to gynecological team, because I have seen several times they have given the tranexamic acid, then patient, because this postmenopausal bleeding within 2 to 3 days again settle, even without the medicine it will settle. But then they have given the tranexamic acid or something, then uh, it's miss. Therefore, it's a very important to don't treat the postmenopausal bleeding outside. It should be actually, if there is a postmenopausal disease, we have to intervene within 2 weeks. So because it's a cancer suspicious, we have to refer to the gynecology team. Initially, we need to start the uh, further assessment, not the management, further assessment. Important thing is, we have to, if we are doing the examination, we have to do the speculum examination, because speculum we can diagnose the endometrial, mainly the cervical causes. Cervical cancer also can present with the post-menopausal bleeding, and the ultrasound scan. You have to assess the endometrial thickness. If this is endometrial thickness is more than 4 millimeter, so most of the time associated with the endometrial cancer. If it is it's a high, if it is endometrial thickness is high, normally we do the histology, and according that we are managing. Therefore, it's important to refer these postmenopausal bleeding to gynecological assessment. Don't treat and send them home with, for that, for these patients. These are difference. Before actually, just I want to highlight in this lecture few things. If you can get a good with a spending a few minutes with a history of a menstrual history, you can diagnose most of the thing, most of the condition, and refer if necessary. You can refer, or if you can start the initial treatment. Even though you can start the initial treatment while you are referring. That's the other thing. And also, please don't treat for the intermenstrual bleeding and postcoital bleeding. They are most of them associated with the pathology. Therefore, please refer. And mainly the polycystic ovary syndrome initially start the, even though you are referring to the gynecological, please start the weight reduction and lifestyle modification. This is also important. It will help the patient. Because if they explain that this is the condition, you can normally I say this is a polycystic. If I diagnose this a polycystic ovary disease, I may clearly says you are going to live with this. This is you are going to live with this in your life. Therefore, we have to do these things. Therefore, then they will also motivate and they will try to reduce some weight. Then it will help for the management in every aspect. And this is the other thing. And other thing is postmenopausal bleeding. Please refer to gynecology. Don't treat the postmenopausal bleeding. If you diagnose postmenopausal bleeding, please refer to gynecological assessment. It's a very important. If you go with these 4 messages after this lecture, I think that's more than enough for outpatient management. You can treat your patient. You can select and treat the patient you can treat, and you can refer to gynecological team if necessary, and it will help the patient also. Thank you very much. If you have any, these are my reference, and if you want any question, you can ask.
Thank you, sir, for all the valuable information you have provided us. I hope everyone has refreshed their knowledge on the topic and learned something new today. Now we move on to the next segment, the much-awaited quiz. Please take a moment to open the link that has been shared on the screen and mark the answers for the compiled questions. While we wait for them to set up the quiz, if you wish to access the previous lecture notes, the lecture videos, and photos of events and other educational material, please use the link to the web space that will also be shown on the screen. Thank you all for participating. The winner of the quiz is Dr. Shanika, and I would like to invite Dr. Hasther to present the prize. Next up, I would like to invite our consultant psychiatrist, Dr. A.G.M. Jiraj, to present the token of appreciation to our speaker today. Now that we have come to the end of the session, I would like to take a few moments to show appreciation for everyone who has come today and everyone who has supported in making today's event a success. First off, I would like to thank Dr. Ruwan Wickramasinghe, our speaker for today, the Obstetrics and Gynecology Department of BH Mahiyanganaya.